Welcome, everyone. Whether you're fresh out of med school or, maybe a few months into your residency, stepping onto the ward as a young doctor carries an incredible weight. You're suddenly the front line. So today, we're focusing on one of the absolute most critical, time-sensitive challenges you're going to face in your medical career: sepsis. In this explainer, we're going to break down the Surviving Sepsis Campaign guidelines to equip you with the exact knowledge you need to recognize, manage, and ultimately defeat sepsis right at the bedside. Let's get started.
Just looking at that rhythm, that line, it instantly anchors us in the life or death context of the emergency department and the ICU. When a patient is crashing, every single second counts. Sepsis just isn't one of those conditions where you have the luxury of time to sit back, consult textbooks for hours, or deliberate over a leisurely coffee. No way. It's an aggressive, systemic inflammatory response to infection that rapidly leads to organ dysfunction and, if left unchecked, cardiovascular collapse. The guidelines we're exploring today, they're designed specifically to help you beat that ticking clock.
Okay, let's dive into this. Think of this as your clinical checklist for your upcoming shifts. First, we'll cover the Sepsis Guidelines Update. Second, the Hour 1 Sepsis Bundle. Third, the key 2021 guideline updates. And finally, applying these guidelines in actual practice.
All right, Part 1. The Sepsis Guidelines Update as a clinical pathway.
Moving right along to Part 2, the Hour 1 Sepsis Bundle, the paradigm shift.
It's vital to understand that the Surviving Sepsis Campaign guidelines are literally living documents. They've evolved over nearly 2 decades, constantly adapting as we gather more and more evidence on what actually saves lives in the ICU. And that brings us to what is arguably one of the most monumental shifts in recent acute care history. See, for years, sepsis care was broken down into a phased approach. You had tasks to complete within 3 hours, and a secondary set of goals to hit at the 6-hour mark. But the evidence showed us something crucial. The pathogen doesn't wait 3 hours, and neither should we. So the old approach was completely tossed out. The 3-hour and 6-hour bundles were combined into a singular, urgent Hour 1 bundle. The entire focus shifted to initiating resuscitation and management immediately upon recognizing sepsis or septic shock.
To understand exactly why they made this change, we really need to look at the official reasoning. The authors stated that this shift reflects the actual clinical reality at the bedside of these seriously ill patients. They wrote that clinicians begin treatment immediately, especially in patients with hypotension, rather than waiting or extending resuscitation measures over a longer period. It's basically a huge acknowledgement that extending life-saving measures over several hours simply isn't good enough when your patient's blood pressure is bottoming out right in front of you.
So what does this actually look like in your first 60 minutes with a crashing patient? Well, the Hour 1 bundle dictates simultaneous, rapid-fire action. Step 1. Obtain blood for measuring lactate and draw your blood cultures before the antimicrobials go in, if at all possible. Step 2. Aggressively administer broad-spectrum antibiotics and rapid fluid resuscitation. Step 3. If you're dealing with life-threatening hypotension that just isn't responding to those fluids, you immediately initiate vasopressors. Now, while the full resuscitation might take more than an hour to complete, the initiation of every single one of these steps absolutely must begin immediately.
Let's move to and see how this builds in Section 3. Key 2021 Guideline Updates, the Modern Toolkit.
Just looking at the official SEP 1 and 2021 Sepsis Guidelines update by CMS really underscores how authoritative these protocols are. After establishing the pure urgency of the Hour 1 bundle, the medical community realized they needed a broader, more comprehensive systemic update to address the entire arc of sepsis care. When major organizations like CMS and the Society of Critical Care Medicine align on these protocols, they essentially become the gold standard framework for hospital systems nationwide.
Released in October of 2021, this 5th iteration of the international guidelines is incredibly thorough. We're talking exactly 93 distinct, evidence-based recommendations for the management of sepsis and septic shock. Now don't worry, we aren't going to memorize all 93 recommendations today, but you do need to know the core categories they cover because they span the entire patient journey. They cover screening and early treatment, initial fluid resuscitation, and crucial source control for the infection. They also dive deep into hemodynamic monitoring and ventilation strategies for your intubated patients. But I really want to draw your attention to the last 2 items on this list, which were entirely new categories added in 2021: long-term outcomes and goals of care.
Now, what's really interesting about this slide is that acute, life-saving care no longer exists in a vacuum.
By explicitly incorporating long-term outcomes and goals of care into standard sepsis management, the guidelines demand that we as clinicians look way beyond just surviving the current shift. We actually have to consider what the patient's quality of life will be after they leave the ICU. We have to align our aggressive medical interventions with the patient's underlying values and long-term prognosis. It's a beautifully holistic addition to a heavily protocolized field.
Which brings us to our final part, Section 4, Applying Guidelines in Practice, Clinical Nuance and Pediatric Care.
Up to now, we've been talking a lot about urgent bundles and strict protocols. But as a young doctor, you're going to quickly discover the gray areas of actual clinical medicine. First off, we have to acknowledge that not every patient fits the standard adult mold. The source material points out that specific, parallel guidelines exist for the pediatric population. The SCCM created comprehensive guidelines catering to infants, school-aged children, and adolescents dealing with septic shock and sepsis-associated organ dysfunction. Because, let's face it, the physiology of a crashing infant is wildly different from a 70-year-old adult, and your interventions have to adapt accordingly.
So the crucial point is really understanding the definition of a guideline itself. The authors are incredibly clear about this. These are intended to guide best practice. They are absolutely not meant to establish a rigid, inflexible treatment algorithm, nor are they legally defining the absolute standard of care. Basically, protocols are tools that empower your medical knowledge. They do not replace your brain.
I actually want to read this direct quote to you because I honestly think it's the most validating sentence you can hear as a new physician. The authors write, "Recommendations from these guidelines are based on the best current evidence but cannot replace the clinician's decision-making capability when presented with a patient's unique set of clinical variables. Every single patient you see is going to have a unique history, a unique presentation, and unique comorbidities. The guidelines are your foundation, sure, but your clinical intuition, your physical exam, and your critical thinking, that is what will ultimately steer the ship." Sepsis management is fast, it is intense, and it relies heavily on both evidence-based bundles and individualized, on-the-ground decision-making. You now know the history, the absolute urgency of the Hour 1 bundle, and the holistic 2021 updates. The knowledge is right there in your hands, so I leave you with this question. How will you apply these best practices to your patient's unique clinical variables on your next shift? Thank you so much for joining me for this explainer, and good luck out there on the wards.